In the fifth and final section of our lecture, now we will talk about our another topic of today's lecture, which is the esophageal neoplasm. Different neoplasm of the esophagus which we will discuss today will be the leiomyoma, polyps, lipoma, fibroma, and haemangiomas. And then we will talk about the carcinoma of the esophagus. So both benign tumors of the esophagus and then the carcinoma we will talk about. So first, the benign neoplasm of the esophagus. Leiomyoma. Leiomyoma is the most common benign neoplasm of the esophagus. It accounts for 2/3 of all benign neoplasms. So it's very common leiomyoma. 2/3 of the cases are leiomyoma. Here you can see the picture, which is the leiomyoma. Arises from the smooth muscle, grows in wall of esophagus. So leiomyomas are the benign tumors of the smooth muscles. So smooth muscles are in the wall of the esophagus. So leiomyoma are in the wall of esophagus. Dysphagia occur because of the growth and obstruction when tumor exceed diameter 5 centimeter. So if the tumor gets big enough to cause the obstruction of the esophagus, when the passage of food becomes difficult through esophagus, and that is approximately about 5 centimeter leiomyoma that can cause esophageal obstruction or dysphagia. Leiomyoma can be discovered on barium swallow, which shows ovoid filling defect. There is filling defect in the esophagus on barium swallow, that is leiomyoma. Endoscopy, also direct visualization of esophagus. The advantage of endoscopy is we can also take the biopsy for the confirmation of the tumor or whether it is benign or malignant growth. So endoscopy is also performed. Reveals submucosal swelling. Biopsy should not be taken. Treatment is an enucleation of tumor by thoracotomy. So again, the tumor is removed, and then the procedure of removing the tumor is by thoracotomy, by opening of the thorax and reaching the tumor. Like polyps, lipomas, fibromas, and haemangiomas. These are some other benign tumors, but we already mentioned the most common benign tumor is leiomyoma. About 2/3 of the cases are of leiomyoma. These are only 1/3 of these are present. So often pedunculated. They have a stalk attached to these tumors. They are present in esophageal lumen. In the opening of the esophagus, they are present. Endoscopic removal of the tumor is usually avoided. Danger of esophageal perforation with the removal. Treatment is the surgical excision and by esophagotomy. So these are the treatment options for these benign tumors. Endoscopy is performed for visualization but not for removal. Can cause perforation of the esophagus. Treatment is by surgical excision of the tumor and by esophagotomy. Next, carcinoma of the esophagus. This is the esophagus, that's the cancer of the esophagus. So carcinoma, causes of the carcinoma is smoking is very common cause, alcohol consumption, particular dietary habits can also cause esophageal carcinoma. 5% arise in pre-existing pathological lesions. Plummer-Vinson syndrome is a predisposing factor. So about 5% of the cases are in the condition which already have esophageal pathology, like patients who have gastroesophageal reflux disease that can lead to stricture formation that can also cause the carcinoma. Then we mentioned some conditions, cardiac conditions that can cause hypomotility, hypermotility. Any predisposing pathological condition can cause carcinoma of the esophagus. What's the pathology in the esophageal carcinoma? The squamous cell carcinoma is the most common carcinoma, and it's present in 93% of the patients. Adenocarcinoma is in the 3%, and this is in the lower esophagus, upward extension of gastric carcinoma. So mostly squamous cell carcinoma, adenocarcinoma, if it is present, it is as a result of extension of the carcinoma of the stomach, and it involved the lower part of the esophagus. Other types are rare. So most common squamous cell carcinoma, some types of adenocarcinoma, some about 3% of adenocarcinoma cases are also present in the lower esophagus. Next, how the esophageal carcinoma spread. Direct spread occur, lesions may fill the lumen, infiltrate wall of the esophagus, spread to the surrounding area like trachea, left bronchus, aorta, involvement of recurrent laryngeal nerve. So direct spread can occur to the local surrounding structures. Or by the lymphatics, cervical, mediastinal or celiac node involvement, cervical and thoracic lesions spread to supraclavicular node. Skip lesion may also occur, and due to direct submucosal lymphatics. So lymphatic spread is through the lymphatics. Then blood-borne metastasis may develop in liver, lungs, bone, and also in the brain. So the spread of the cancer, esophageal carcinoma, can occur like any other cancer through the direct spread, through the lymphatics, and through the blood supply. Clinical features are the early symptoms which are present: substernal discomfort, preference for soft or liquid food. Progressive dysphagia, so in the early stages, usually there is discomfort, but as the cancer progress or grow, they can cause dysphagia. Patient become weak, wasted, they cannot eat properly, so that is the reason for emaciation. Dysphagia first to solid and then to liquids. Patient loss weight, becomes emaciated. Pain is present, which is signify extension of tumor to distant areas beyond wall of esophagus, referred to the back. Aspiration problems, laryngeal paralysis or fistula formation, cough, hoarseness, aspiration, pneumonia, and mediastinitis. So all these are the features associated with carcinoma. Again, in the beginning, when the size is small, the features are different, but as the tumor grow and progress, the symptoms are different, and it can cause serious effects. The diagnosis of the cancer barium swallow shows narrow and irregular esophageal lumen without proximal dilatation of esophagus. So there is swelling present in the esophagus. Esophagoscopy sees site of involvement, notice extent of lesion, take biopsy, and flexible fiber optic esophagoscopy obviates gives magnified view. So these are some diagnostic tests that can be performed. Bronchoscopy exclude extension of growth into trachea and bronchi. CT scan to assess the extent of disease and then nodal metastasis. Treatment of the carcinoma is the surgery of upper two-third, difficult due to the presence of great vessel in the upper third, involvement of mediastinal node. Radiotherapy is done. Surgery for lower one-third. So lower one-third surgery is done. Upper two-third is the surgery is difficult because of the presence of great vessel. Radiotherapy is preferably performed. In the lower third, the surgery can be performed. Again, the treatment also affected segment, wide margin of esophagus proximally is removed, fundus of stomach distally excised with primary reconstruction of food channel. So the portion that is affected is excised and then the channel or path is created for the passage of the food. Again, depending on how big is the tumor, how far it is spread, or if it is localized, then the treatment options will be accordingly. Cancer removed, stomach pulled up and joined to the remaining esophagus. So part of the esophagus that has tumor that is removed and then the channel or tunnel is created. Alternative food channel provided by a bypass operation, esophageal intubation with celestin or mosebarbin or similar tube, permanent gastrostomy or a feeding jejunostomy, laser surgery, which is YAG laser, is done. So these are all the different treatment options for the carcinoma of esophagus. Prognosis, 5-year survival is not more than 5 to 10%. So poor prognosis, 5-year survival is only 5 to 10%. That concludes our today's lecture. Thank you for watching sqadia.com.